I'm going to go ahead and mute everyone. Hi, everyone. Welcome to our very first virtual briefing for the League of Women Voters of Chicago. My name is Ann Jameson, and I am the board president of the League of Women Voters of Chicago. Just to give you guys a quick introduction for those who might not know, the League of Women Voters is a 100-year-old organization that aims to give everyone the right to vote and to make sure once you have that right to vote, you are voting informed. So we register voters, we do voter information, there's a ton of stuff that we do. If you want to find out more, the easiest way to do so is honestly to Google League of Women Voters of Chicago and click on our website, or find us on Facebook or Twitter. So I'm going to go ahead and hand it back to Samina and to introduce our speaker. So, Samina?
Yep. Thanks, Ann. Appreciate it. So welcome again. My name is Samina Mustafa. I'm the co-chair of the Committee on Diversity and Inclusion at the League, and excited to introduce our next speaker. I've met Dr. Rogers through organizing on healthcare equity and universal healthcare. She is the president-elect of Physicians for a National Health Program, which is a 20,000 member organization. She is going to be assuming her role in 2021. She is a retired, but is a volunteer attending hospitalist at the John H. Stroger Hospital of Cook County, where she also completed her residency, and she received her medical degree from the University of Illinois College of Medicine, and has been speaking on healthcare equity and advocating for single-payer healthcare for many years. So I wanted to hand it over to Dr. Rogers. Welcome.
Okay, well, thank you so much for asking me to join here, Samina. I am going to put up my slides now. Let me see here. Okay, can everyone see my slides?
Yes.
Okay, good. Okay. Like I said, thank you so much for asking me to do this. And I think health equities have really sort of been highlighted in the media light, especially with the pandemic from COVID. And we have to remember the inequities have always been here, but it's always been kind of in slow motion. You know, they were happening, but nobody really acted as if it was an issue. And now that with this pandemic, it's like up in everyone's face and you really can't ignore it. And what I'd like to go through today is just kind of the history of why these inequities are here. We hear a lot of talk about, well, if poor people just worked harder, or poor people made better choices, or da-da-da. But that's really not the answer here. There's always a lot of victim blaming, and that it's the victim's fault, this and that. But what I want to go through is the history of all the structural inequities and the structural racism that has been done in this country that created these inequities, and not only just created them, but helped sustain them. And one of the things with our healthcare system here in the United States is that the economics of medical care here have made poor patients the ones that no one wants to treat. We have multiple payers in our health system today. Private insurance tends to pay physicians and hospitals the most, and that implies that people have to have a job and they have to be able to access their health care and all that, which leaves out poor people. And if you look at how Medicaid is funded, it's really, the reimbursements are so low that they often don't cover the costs. Medicare even does not often cover the costs of the health care that people need. So that these patients, people don't want to treat because they aren't reimbursed, and there's no reason why, if I'm seeing a patient with hypertension, I should get reimbursed more for taking care of someone who can pay me more than for someone else who can't pay me as much. It's the same care. And it leads to just some of these inequities that we have. And until we change our healthcare financing system so that poor patients are worth as much in reimbursement as wealthier patients, we'll always have these inequities. But I also want to focus on why the inequities are here. So what are health disparities? Well, disparities just refer to differences among anything, population group, socioeconomic status, where you live. It can be almost any group, and there can be disparities because you are in a particular group, but you're in a group not necessarily because it was created. That's just where you are. And so they don't imply any personal reason for you to necessarily have those disparities. And it's interesting that the United States uses the word disparities, but the World Health Organization and Public Health uses the word inequities. So what are health inequities? Well, I like to think of an inequity as something that has a moral and ethical dimension. It refers to something that should not be there. It's unequal. And because it's unequal, it's unnecessary, it's avoidable, and we should consider it unfair and unjust. So how can we achieve healthcare equity? Well, the main thing is you have to allow equal access for equal need. And that means that if two people have the same need, they have the same medical problem, they need the same medical test or whatever, that they should have equal access to that. And right now we don't have equal access. We have financial barriers to care because of insurance. We have areas where there is not healthcare providers or places to go for that care. So you have to have everybody able to access the care they need for an equal need. We also have to have equal utilization for equal need. And by that, I mean that you have to be able to access the care. You have to be able to get there so that everybody who needs a certain thing for health can get that need. You have to be able to provide that utilization. And what we have now is that we have areas where you can't provide that utilization for that care, so that you have unequal utilization. And then we have to have equal quality of care, and that is that each hospital should be able to provide the same quality of care. You shouldn't have lesser quality in a poor neighborhood than you do in a wealthier neighborhood. And you have to have providers that are committed to providing the same quality of care wherever it is that they provide that care. So we have to have all this equal access, equal utilization, and equal quality of care for all before we can even achieve healthcare equity. And if we look at what happened, say, with public education, even though that it was determined by the Supreme Court that it would be separate, it would be integrated and all schools would be equal, we clearly know that there have been issues with that persist. So throughout the history of this country, there's been a lot of things that have tried to explain some inequities, some of the inequities within racial groups. And there have been studies back during slavery. There was a physician who took skulls from whites and from slaves, filled the skulls with seeds, and decided that the size of slave skulls was smaller, and thus he deduced that this meant that Black slaves were inferior. However, it did come up that the way he did his study was inaccurate, because there was a physician in Germany who was actually doing the same thing who came up with a totally different conclusion. So they tried to do these things to justify the inferiority that they felt was an issue with Black people, especially slaves at that time. There was even a doctor that came up with a disease called drapetomania, and this was a disease, it's actually, I don't know how people come up with things like this, but it was a mental illness that slaves had, which made them want to run away. Now, to me, wanting to run away was a sign of good mental health. because you realize your situation was so poor. But they just described this as being abnormal for a slave to want to run away. Then there were studies on the lungs, and this started coming up around in the 1800s when tuberculosis was a really big issue. And what they found was that they used to do studies, and any of you who have asthma or any lung disease, you breathe into a tube and it measures what we call your vital capacity, how much air your lungs can hold. And what they found in doing this was that slaves actually had a smaller vital capacity than whites did. And so they looked at this as they were inferior. And the way to help that was to have them work hard, so that by working hard, their lungs would work harder, they would get more blood to their inferior brain, and then they could function better. And this also justified them in thinking that they were not able to handle freedom. Pain control is another one. There have been a lot of biases, and studies have shown recently that physicians often do not adequately treat Black patients and other minorities for pain when they present with a long bone fracture, for example, which everyone knows this is extremely painful, but they were often not treated. And this is a biased feeling that Blacks and other minorities can withstand higher levels of pain, or that they are just drug seeking, or that it will lead to further addiction. And it's interesting though, because a lot of the opioid crisis has been in mostly white people, because Blacks were never given prescriptions for opioids the same. And then this is recent, back in the 2000s, there was a drug that came out, Badil. And what Badil was a combination drug for end-stage heart failure. Now, when I was in medical school a long time ago, there were two drugs that came out that were now, that were just found that would be very helpful with end-stage heart failure. And so there was a study done back in the 2000s that showed that if you combine these drugs, it worked even better than having to take two separate pills. And so they did a study, and within this study, which was mostly white patients, it showed that Black patients may have done a little bit better in the study than the whites. And so this doctor, what he did was he changed the pill, changed the doses a little bit, and combined the pills so that he could now patent it, because it was technically a different medicine, and that's all the patent authority had to show. And so he did a study that only included Black patients, and he showed that they did improve. And so the FDA approved this drug by saying that it would help Black patients with heart failure. Now, there's two things we need to take away from that. And keep in mind, this is in the 2000s. This is recent history. This isn't back in the day when studies were trying to prove that Black people were inferior or that they were genetically different. The genome study has shown that there is no genetic difference between Black people and white people. And even today, when we have guidelines, and that's how we practice medicine, we have guidelines that are proven and effective. And the thing to remember is that they're based on studies that had mostly white people in the studies. And so that data with mostly white people was still extrapolated to be used on everyone. So nobody said this was only guidelines for white people, it was for everyone. But now there's a drug proven that works with Black people, but it's marketed as saying this only works for Black people, it doesn't work for white people. So for some reason, Black people are just so different that we can't extrapolate that data and use that with white patients too. So this just continues the whole idea that Black people are different, our bodies are different, we respond differently to medications, and there must be some genetic thing with being Black, even though we know being Black or white is a social definition. It has nothing to do with science, it has nothing to do with genetics at all. So Back in 1899, W. Du Bois wrote a book called The Philadelphia Negro. And what this book was, it was the first academic challenge, really, to these oppressive explanations for the racial gaps in healthcare that were occurring that day. And what he did was he studied TB because Blacks who were living in poor neighborhoods with poor sanitation, poor services, poor food compared to white neighborhoods were dying more and having worse issues with TB. And what he did was, I don't know how he did this, it's amazing. He did this back in 1899 with pencil and paper, but he was very meticulous about the data, and he showed that Black patients did worse because of the lack of sanitation, because of poor health, because of underlying poor bad opportunities to get good food, and just poor housing conditions. And what he actually did has changed the way public health was done in the way they approach studies. And it really changed the conversation more towards what we now call the social determinants of health in affecting health outcomes versus race. And even today, the methods that he used are still being used. And so this is just a little timeline that I wanted to put up to just sort of talk about what has happened in this country. And I'm going to highlight some of these government, federal and state policies that were done that have contributed to the inequities that we see today. And prior to the end of the Civil War, almost 90% of Blacks were slaves at that time. And then when the Civil War ended and then Reconstruction was started, things actually improved. There was a 15th Amendment that allowed Black men to vote. Of course, women couldn't vote then, but Black men were allowed to vote. And then in the late 1800s, Reconstruction ended, the resurgence of the KKK, and with its terrorism and Jim Crow policies, things, things got much worse. And so I'll go down some of the things in this list here. Now, I think the biggest thing that came out of this was segregated housing, and segregated housing has been in place since day one. And this is just a sign that was put up in a white neighborhood in Detroit in the 1940s, saying they wanted to keep white tenants, they wanted only white tenants in their white community. And this was in response to a housing project that was going to be built next to their community. They did not want them there. Now, in 1934, the FHA finally established what we call government secured mortgages. And this was rather new then. Before you got mortgages through banks or whatever, you still do, but they weren't secured by the government. And so what this meant was that there was much less risk to giving a person a mortgage if the government secured the loan. But what we have to realize is that of all the loans that were approved by the government for the next 30 years, whites received 98% of them. And that had nothing to do with the fact with Blacks being unable to pay these mortgages because they could, but there were policies that allowed them to restrict these loans. The biggest of which I think is redlining and the restrictive covenants that came from that. And what redlining is that as the government went and said, this is a low risk mortgage or a high risk mortgage, this is what these mortgage companies did. And what they said is that any community with a Black person in there was a high risk area to buy a home, and they would not secure a mortgage in that area. And so on maps, they were redlined. And so what this meant was that a Black could not get a mortgage because they were not what they wanted to buy and what they considered a high risk area because Black people live there. And this is, it's just sort of self-destructive. It's, if you say that, you know that it isn't going to work. And so what it did is it forced families into contract mortgages, which were mortgages put out by some banks, and then some private corporations funded it, but they really weren't mortgages. They were more like a rental ownership thing, whereas the person who was buying the house would pay monthly. However, they didn't accrue equity the way you do with a regular mortgage. As you pay down your mortgage, you own more of your house. But here, you got nothing for the house until you paid the last payment. Then it became your house. In the meantime, you function more like a renter in the sense that as an owner, in the sense that you had to fix everything that broke. Now, along with these mortgages, these areas were often over assessed so that the taxes were high. These communities often didn't have good schools, other services that communities wanted, the things that we look at that say this is a nice community to live in. And many of these mortgages were defaulted on because if they missed one payment, the lender would take the money back, would take the property back, and because nothing was being accrued in there, the person had nothing. They ended up with absolutely nothing, even if they had been paying on that for like 10 years. And the other thing that was done, these restrictive covenants meant that you couldn't sell. If you were a white community, they had laws that said you could not sell to anyone Black. And even though this was illegal, it was never really enforced by the government, and that they came up with really creative ways to get around that too. They would say, well, you couldn't buy here unless it was legal for you to marry anyone on the block. And at the time, interracial marriages were illegal. So if you were Black wanting to buy in a white community, knowing you couldn't marry anybody in that community, not that you wanted to, but you couldn't legally, they would not sell you the house. And so what happened is that Blacks were disenfranchised from buying property, which at the time was the main way that people accrued wealth. They buying property, owning your home. And it had nothing to do with whether Blacks could afford it or not, because many of them could. Many of them were more than able to pay for a regular mortgage, but they were restricted. And this even happened again, even though, we all realized that this redlining and all of this contract was not right. It was not moral. But even in the 2000s, we had these subprime mortgages that were sold by banks that preyed on minorities. And even when a minority would apply for a mortgage and would be eligible for a better mortgage, they were directed towards subprime mortgages. And then the market collapsed because as the rates went up, people could not afford those mortgages. So this predatory lending has continued over the years, and it has continued to keep Black families from accruing wealth in their property and being able to live in a community with all the benefits that we all understand make a community good to live in and to raise your home. So this structural racism that was established years ago has continued. Nothing has changed. And I think that's what we have to realize, is that these things are ongoing. You hear a lot, slavery's been over for a long time. Yes, it has, but the policies and the attitudes of white supremacy and the ability to circumvent the law has not changed. And this is just a picture of what redlining looked like. And the patch in the pink or the red that you can see, it was the only place that Black people could live. And so Black people didn't choose to live in poor neighborhoods. Black people didn't choose to live in areas without services, without good schools, without good sanitation. This was the only place they could live. And so the separateness has just contributed to the entrenched inequalities that are there. And there's an enormous wealth gap now between the races because of this. And it's led to unequal access to public education and, of course, unequal access to healthcare. Now, I mentioned about the wealth gap, and that this just shows how over the years, Black Americans have not been able to really accrue anywhere near the wealth that white families have been able to accrue, because they haven't been able to own property, and they have been forced to live in areas that were not consistent with a healthy life for a lot of reasons. And I think that wealth is actually more important than income. You can have two people who have the same income, but if one person has wealth, they're more able to take care of an issue that comes up that's unexpected. They are able to go to the bank and have a loan because their credit score is better. They have some assets as collateral. They are able to help their children when their children need help. Black families aren't able to do that. And so this wealth has really contributed to the continuation of all these inequities that are there. And what has happened with Blacks and minorities being forced to live in certain areas without amenities like good education, good grocery stores, services, lack of transportation, lack of jobs, is that we now have areas of concentrated poverty. And by poverty, concentrated poverty is where 40%, 30% or more of that community is at or below the federal poverty level. And let's be clear about what the federal poverty level is. It's a level that was developed back in the 60s by Social Security, and it came up with data that decided this is the minimum that a family would need to be able to survive for 4 weeks. And this was the minimum, and it depends upon how many in your household, what the federal poverty level would be. But it would be enough for you to pay your rent, to buy food, to pay for utilities, transportation, things like that. But it was designed for you to be able to live for a month. It was never designed to be adequate for living continually. It was not that. So people who live in concentrated poverty, who are at that below the federal poverty level, and we all know that even being above the federal poverty level, you are still poor. But to live in concentrated poverty, you are surrounded by others who are also poor. So when you're surrounded by people who also have nothing, it's a whole different psychological dynamic. The neighborhood, the environment is different. And this is important because there is a big difference between Black poverty and white poverty. And you can see in this slide, and Chicago is the perfect example of this, in that in Chicago, 35% of poor Black people live in areas of concentrated poverty. Less than 5% of white people live in areas of concentrated poverty. So what that means is white people who are poor still have access to good schools. They still live in a neighborhood where there is a grocery store where they can buy adequate housing. They still live in a neighborhood where there is adequate transportation, where there are businesses where they can have jobs, where they can work, so that the resources available to poor Black people are much more restricted than those that are available to poor white people, because poor white people are not living in concentrated poverty the same. And if you look at these cities, it's throughout the country. And even if you look at the country statistics, 25% of poor Black people in this country live in areas of concentrated poverty, whereas white people less than 5%. And so segregated housing is now increasingly due to zoning policies. We can't say you can't live here because you're Black or because you're poor, but what you're saying is, I don't want you here, so you make a zoning policy that reduces affordable housing options so that the government will not support your rent for you to live here. And this is what neighborhoods do to keep their neighborhoods restricted so that they don't have poor people coming in and it remains comprised of more wealthy residents. And all the things that neighborhoods need have purposely not been provided in minority communities. There's not education, there's not arts, there's not employment, all the social determinants of health that we all realize we need to stay healthy. None of these are there. So you've got communities that function more on survival, living day to day versus planning for the future. And the segregation really is based on the assumption of what is superior and what is inferior. And because of that, it makes impossible for that to be equitable. And this is just a slide to just show that even in Chicago, these inequities are glaring. If you take the train and you go through different communities, and this just shows how the life expectancy, if you start in East Garfield Park and you go downtown, people who live downtown are going to live about 13 years more than you just because of where they live. And people who say, you've heard the comment about your zip code is more important than anything else, and we're in terms of health outcomes and life expectancy, this is true. And you can find this on the Robert Wood Johnson site. They have a lot of graphs like this for different cities, but clearly we have pockets where there are very large gaps in healthcare. So let's talk about some of these federal policies that have persisted in supporting and creating these policies going on. Continuing. So let's talk about the Social Security Act. And this was developed back in 1935. And this was FDR's New Deal. And everybody raves about how the New Deal, which was in response to the Great Depression, and there were so many communities that were needy. And one of the things that's similar about that situation and what we have now is that the president came up with the New Deal because states and communities were bankrupt and they needed financial support from the federal government. And that is exactly what is happening now. You've got states and communities that are getting no revenue and are going to need federal support to help them to continue to function. So what the Social Security Act did, it established a system with old age benefits for workers, benefits for victims of working accidents, unemployment insurance, and it started a aid for dependent mothers and children, which we now call welfare. It helped the blind and the physically handicapped, and it did all this to help them because the states couldn't do that. Now, one of the things I think that a lot of people don't realize that who was eliminated from being able to receive benefits from Social Security? Well, farm workers weren't able to benefit from that. And who were most of the farm workers? In the South, it was more blacks than there were whites. And I'll get to that in a minute. But there were more black farmers after slavery in the South than there were whites. And so they were not able to avail themselves of Social Security. And then the other group that was not allowed to be eligible were domestics. So who were the maids? They were black women. So here you have black men farmers can't get Social Security. Black maids and housekeepers cannot get Social Security. So this deal, New Deal, which was supposed to bring about all this regrowth in the country, totally disenfranchised most of the black people who lived in this country. So this was not by accident. And then when we look at the Aid to Dependent Children and Families, this was called ADC. And what this was originally, it was created for white women who who weren't expected to work. But what happened was that there were a lot of support for this, but what happened was that the federal oversight to this program was eliminated. And so there were things there that totally disenfranchised black families. For one, in order to get this aid, you had to have suitable housing. Number one, you couldn't have illegitimate children. There were all these factors, and it said explicitly that colored children were not going to be supported by this. So this was another program that totally disenfranchised Black women and their children. And interestingly, when this program ended in the 60s, I think it was, it then became an entitlement to Black women. It wasn't looked at as an entitlement to white women. It wasn't looked at in a negative way, that you should be working, you don't deserve that. But then when it became a program to help Black women, it was. And so this is just the perpetuation of these inequities by federal government policies and even state policies who distributed this, so that they weren't able to take benefit of this. And, you know, we can see what has happened over the years. The other thing that I think is particularly awful that this country has done is the way it treated Black farmers. And if you look at the turn of the century and after Reconstruction ended, there were more Black people in the South than there were whites. There were more Black men than there were white men. And Black men were able to vote because of the 15th Amendment that came out of Reconstruction. Well, this was seen as an intolerable situation to the white farmers down in the South, especially in the Mississippi Delta and Alabama, Florida. So there came to be a lot of discriminatory loans. Black farmers were often, the land was often stolen. They didn't have legal access to secure that. There wasn't a way to formally pass this land down to children and other family members because of the difficulty navigating the legal system, and there often wasn't any legal recourse. Over the years, as people started getting involved with the NAACP and the Civil Rights Act, those farmers were, along with just the Jim Crow and the terrorism from the KKK that was going on in this time, they were not allowed to get loans. So over the years, the Farm Security Administration just totally stole the land, and Black people were often left with nothing. And then finally, white men became a majority in the South as Black people started migrating north, and they lost their land, so that they did what they wanted. They kept their majority there. And the thing to remember too is that a lot of these policies were delivered by the government that was totally white in the South, which actually had no sensitivity or empathy for the Black farmers that were living there. And by the time that Black people really truly gained the ballot in the South, which was around, the 70s, they were now in a minority, so that there wasn't an ability for them to redress this. And then in the in the 1980s, and this was when the farm crisis came about and there was a lot of need for federal assistance, it still was not possible for Black farmers to get this. And in 84 and 85, at the height of the farm crisis, the USDA lent a total of $1.3 billion to almost 16,000 farmers to help them maintain their land. And out of that 16,000 farmers, only 209 farmers were Black who received that money. So it's clear that all of these policies that were developed that were supposed to build the country legally disenfranched Black people, and the continued segregation that they were forced to live in, the lack of resources. You can see how things have not improved over time the way it has for the majority white population here. And this is why, part of the reason why these inequities have continued and why they are still here today. And I want to talk a little bit about the GI Bill. The GI Bill was developed after World War II to help the GIs who came back from the war. Now, this was federally funded, but it was state administered. So the states all decided what they wanted to provide. So there were a lot of home loans that went to Blacks, and this is when suburbia started being built up, and there were all these communities and all of that. But Blacks couldn't get home loans. They couldn't get them because of the FHA, the way it was structured. So out of 67,000 home loans, only 100 went to Black GIs. So despite this supposedly being the opportunity to help the GIs get back on their feet and do whatever, it legally disenfranchised Black GIs. The VA loans, which were supposed to go to GIs, only 2 out of more than 3,200 VA loans went to Black GIs. The training facilities for the GIs to get a new skill, to learn something different, to get a different career or whatever, all of these training facilities were segregated. And so even though they were not available to Blacks because of segregation. College loans, in the South, the colleges would not admit Blacks. The Tuskegee Airmen were not allowed to become commercial airline pilots. And although the commercial airline industry was small at this time, it still was there, and they were not able to avail themselves of that. And even my father, after serving in the war, he came back home, and he still had to sit in the back of the bus when he went home to Macon, Georgia. Now, there is also fear of healthcare by minorities, and I think a lot of this fear is very well founded. There's a book, Medical Apartheid, by Harriet Washington, and I apologize, the slide isn't clear. When I tried to make the image bigger, it just wouldn't clear up. But anyway, this book was, I think, written about 10 or 15 years ago, and it just goes through the history of some of the awful, awful things that were allowed to be done to minorities starting back in slavery. And I think we're all well aware of the Tuskegee syphilis study, where men went over 25 years of not being treated for syphilis, despite us knowing that penicillin was the cure and it was widely available, but they were not treated to just see how the disease progressed. And what this did is it not only affected those men, but the women that their wives that they had children with, the wives got it, the children got it, they got congenital syphilis. So this had an exponential effect. So this is actually, the Tuskegee study is one of the more, not one of the worst things that happened. Some of the things that have that were done in the name of science were just really egregious. And the Nazis learned a lot from what was done on slaves in terms of the studies that they did on the Jews in the concentration camp. I mean, they learned from us all of these egregious acts. And so there is real fear of by minorities from healthcare, and I think it is well founded. And this is just a statue. There's this man, Dr. James Sims, who was called the father of gynecology. There are endowed chairs under his name at universities and hospitals for the Department of Gynecology. And this was a man who, back in the early 1800s, did a lot of surgical studies on obstetrical complications. Now, he did this on slave women. He did them without any anesthesia. And it was felt to be okay, that this was okay for him to do this. And what's most disturbing, too, is that this work is still applauded by the obstetricians today. And this is a statue of him that was in Central Park that wasn't removed until 2 years ago. And this is a man who made his name by, mutilating Black women slaves over the years, and he was still supported by gynecologists today. And so we talk about Confederate monuments, we talk about all these other things, but there's also other people who are still honored in this country despite the acts of violence against Black people that they have done, and nobody questions that I think that people just don't know. If you had walked by the statue, you wouldn't know anything about it. You would have thought, oh, this was a great guy, because we don't know. None of this is taught. And so if we talk about Medicare and Medicaid and 65 and the Civil Rights Act and all that, that was really transformative, because hospitals were all segregated up until then. And it wasn't until the Medicare and Medicaid that hospitals finally became desegregated. And this was because Johnson said, if you want this federal money, you have to be desegregated. And there's Dr. Martin Luther King standing right with him. So this was part of the civil rights movement, to get hospitals integrated, to allow Black doctors to be able to be on staff at these hospitals, because at the time, this was opposed by the AMA. And it was the AMA who decided who could be on staff. It was the AMA who decided that Black medical students could not do fellowships or residencies in these hospitals. And so it just disenfranchised Black physicians from being part of the mainstream medical care at the time. So this was transformative, but even a lot of hospitals still didn't desegregate at the time, the same as schools in a lot of areas did not desegregate, despite Brown versus the Board of Education. So this was instrumental, and it started, but we know now that things tend to be moving backwards. We'll get to that. A couple other things that affect some of these inequities with Black patients is a condition we call weathering. And this has been talked about by sociologists for a lot of years. And what it is, it's just the stress of being Black. It's the stress of driving while Black. It's the stress of jogging while Black. It's the stress of being in a park while Black. And all of this creates stress. And they have found that it increased cortisol levels, which is one of the hormones that goes up in stress, leukotrienes, other chemicals that your body produces in response to stress. And that over time, this really does affect your health. And that there's no way to test for this. There's not one specific blood test, but over time, I mean, and this is part of the feeling as to why even when you account for socioeconomic classes, Black people still have they die sooner than whites, and they suffer more from chronic diseases despite the no difference in socioeconomic status. And then there are fewer minority physicians now. And so we all know that we like to go to a physician that we want to go to. And minorities would often prefer going to a minority physician because of the history in this country. But there's a lack of minority physicians for a lot of reasons. We've already talked about the neighborhoods that isn't developing a big enough pool to produce more. Just the stress of dealing in the medical field as a minority physician is difficult. I remember going through medical school, and I always felt that I was assumed to be stupid until I proved that I was smart. And I think that is still going on today. Mass incarceration is affecting the lack of the pool that's available to become minority physician. So it's really a reflection of what is happening in the society as a whole. And we can talk about the ACA, which did help with some of the inequities in this country. And the Blacks that lived in expansion states now are just as likely as many white adults in those states to have a usual source of care. And by usual source of care, I mean they're able to go to a clinic or to a private doctor's office or access a community health center. They won't have to go to the emergency room for their usual source of care as much. And this is a statistic that is used to sort of just designate how healthy a community is. But unfortunately, expanded Medicaid didn't occur everywhere, and it wasn't available to about half of the Black adults that are working age in this country. They live in the states that did not expand Medicaid. And this is what contributes to these further inequities, that this was a choice. And when I say inequities are avoidable, they're cruel. This is what happens. These are the decisions that people are making, that they choose not to expand Medicaid, knowing that it would help improve the status of not just Black people, but white people too, because we all know there are more white people on Medicaid than there are Black people. So they are disenfranchised too by this lack of expansion. Now, I wanted to talk a little bit about COVID because that's what's happening now. And this is just a slide. There's a lot of data out there, but I think that the crux of all the data is showing that despite the whatever percentage in the population that Blacks and other minorities have, we have way above that in terms of our percentage of the total number of cases and the total number of deaths. And the total number of cases is probably totally underestimated, I think, for a large part of the country. But it's also more so, I think, in Black communities because they are not set up there. A lot of Black people do not have a car, so they are not able to go through a drive-through testing. All the other inequities in life affect their ability to get tested. And knowing that we suffer more from those inequities, Black people are less likely to get tested. And not that testing necessarily is the end all, it is a necessary part of dealing of this virus. And knowing that the way people are forced to live, if you look at minority neighborhoods, that the difficulty in being able to socially distance is even more difficult. You can look at the streets, and a lot of communities, you see vacant lots, you see boarded up houses. So it's not that the streets are necessarily full of people, but the homes are. And there's a difference between neighborhood density and housing, which is crowded. And what happens in minority neighborhoods, and this is in immigrant neighborhoods and other minorities and communities with people of color, is that the houses are often crowded, and by definition we mean there are more people living in the house than there are rooms. So if you've got a 4 or 5 room home, and this doesn't count bathrooms, and you've got 10 people living there, your house is crowded. There's no way you can socially distance in your home. And this is why the virus tends to spread. People cannot socially isolate themselves, even if they can walk down the street by themselves. And you've got multi-generational families often living together. So you've got a younger person who may be infecting an older person who is at higher risk of complications and dying. And this is just another slide just showing the impact. You've got Louisiana, which is only 32%, the Black population is only 32%, but there are 70% of the deaths. Same thing in Illinois, 15% of the population, but 42% of the deaths. In Chicago, it's twice as many deaths for the percent of the population. And these keep repeating themselves. And the reason why I think I tried to make clear with, you've got these communities that have been created, that were created to not just produce, but sustain the inequities that are there, that just this pandemic just exposes. And it was quite surprising how even the AMA's response was, we need to do studies to find out why. But the studies have been done. It's quite clear. The Institute of Medicine did a big study back in 1990 talking about the inequities. And they found that it was more the social determinants of health and the social environment in which people live. So let's talk about how these things have helped and how the CARES Act has helped with these, address some of these inequities. Well, the CARES Act, which is the Coronavirus Aid, Relief, and Equity Security, and it includes the Paycheck Protection Act. But one of the things with the small business loans that came out of this is that it was a system that was first come, first served, and it ran out of money within 2 weeks. And the problem is that a lot of small businesses, and I don't know how they came up with the definition of a small business at 500 or less employees, because I don't think that's really how they define a small business. But you have a small business in a minority community that may have 2 or 3 employees. They don't have an attorney. They don't have a staff to navigate this paperwork. They may not have a relationship with a bank. And keep in mind, a lot of minority neighborhoods do not have banks. There's not a bank location within this area. They have payday loans, they have currency exchanges, which inordinately cost more. They cost people more to get money that way. They don't have banks. So just by building the system like that, put small businesses, especially minority business, at a disadvantage. And it's clear that when they ran out of money, a lot of this money never trickled down to these smaller minority businesses, yet these huge companies were able, with their attorneys, to navigate the system, jump through the loopholes, and they were able to get millions of dollars. So it was just another policy that disenfranchised Blacks, just like the New Deal. It was supposed to help the economy build up, but it still disenfranchised poor people and people of color. So there was little connection between who really needed the money and who was actually getting it. And then if you look at hospitals that got money, hospitals in poor neighborhoods often do not have most of their revenue come from private insurance. Private insurance pays the most per care. And this is why a lot of these very wealthy hospitals are losing money now, because a lot of their patients are COVID. They may not be insured. Meanwhile, they're not getting all of this money they're used to getting from elective procedures and elective non-emergent health care, provided that it's paid by private insurance. And so what happened is that hospitals who had the highest share of private insurance revenue, that is, they have more commercially insured patients, less poor patients, less Medicare and Medicaid. Those are often the hospitals who, many of these hospital groups are sitting on billions of dollars. So they're not going to go bankrupt. They're not at risk of that. But they're getting twice as much money per bed as another hospital who has mostly Medicaid or Medicare patients. Those are the patients that are least able to financially withstand this crisis. They have a population that is most needy. These are areas, not just in urban areas here, but in rural communities. And so this is, again, an inequity that is sponsored by the government, that hospitals who need it the least get the most. And this is repeating. This is the same thing that's happened, almost a century ago. The same thing is continuing. So I think we have to acknowledge that you can't have a disadvantaged group without there being a group that is advantaged. And the thing is that part of the difficulty in recognizing being advantaged is that has always been your normal. That's all you have seen. You have always been within that advantage, that area, and you've always felt that this is normal. You grow up in a neighborhood with good schools and good grocery stores, and you think that that's normal, but it isn't. It's normal for you because you are advantaged. And I think that part of the problem in this country is that poor people remain invisible. You have expressways that circumvent poor neighborhoods. You have streets that with cul-de-sacs so that you don't have to go through to get to other neighborhoods. It keeps the poor people out, so that until people realize that they are advantaged, that they are entitled, and that poor people are poor because they're disadvantaged, not because they're inferior, not because they don't work hard, not because they make bad choices. Oftentimes there is no good choice. It's the poor people who have to choose, should I go to work and risk getting COVID and dying, or should I stay at home and risk being hungry and homeless? there's no good choice to be made here. And the ability to make good choices means good choices have to be in your list of choices. And for disadvantaged people, there are often no good choices in their list of options. So what single payer healthcare would do, and we'll jump to that, to just say that it won't solve all the inequities that we have in healthcare. It won't solve everything that's going on. However, it does make things better. And the way this would work is people would pay a tax, a payroll tax, business would pay a tax. And keep in mind, this payroll tax would be based on your income, which is a progressive tax. Because why is it that if you make $30,000 a year, you pay the same premium for your family that the person who makes $150,000 a year pays the same amount? So it's taking a higher percentage of your salary than it is theirs. However, if we had a tax that was based on your income, you would end up paying much less than people who make more, but people would still end up paying less than what their premiums are now. The money would all go to the government. The government would then fund the health plan. The health plan would then reimburse the doctors and the offices and the hospitals where the care is delivered. And it would be a much streamlined system. You don't have to worry about, does my health plan cover this? Will my health plan allow me to see that doctor? Will I be able to go here for that? It would all be one single system. And believe me, people who live in single payer systems like it. And nothing is perfect. But clearly, covering everybody for healthcare has to be one of the ways that one of the things that we have to insist on if we want to make everybody healthier. And it is to everybody's benefit that we are healthy. You want the person who's cooking your food when you go to a restaurant to be healthy. You want the person who's putting your silverware on your table to be healthy. You want the person who's ringing up your groceries to be healthy. So these are the things that, you know, we want them all. We want everybody to be healthy, because if everybody is healthy, everything works better. And it's not just individuals. We have to look at the whole community. And so this is what PNHP, of which I am a member of, this is what we see as our next steps. We need to immediately protect patients from the medical costs due to COVID. And there is a bill out now that will cover all costs for everything related to COVID up until we get a vaccine or the pandemic ends. I think it's when we get the vaccine, and maybe if we don't get a vaccine, it'll cover it indefinitely, but we have to be able to cover those medical costs. And we also have to cover all other medical costs, because even if you get over COVID, you will still have medical costs related to that. There are still other medical issues that people have who may not have had COVID that still need to be covered for. We need to restore our public health infrastructure. We need to listen to the health experts rather than a politician who was worried about being reelected. Incarceration is a petri dish for infectious diseases like this, and we need to protect those, especially patients who are in jail because they can't afford a $50 bond because of parking tickets. They're not endangering society. They are just poor. We need to protect immigrant patients. And what people don't often realize is that immigration, because people often work under false Social Security numbers, they provide more money into Medicare than they ever take out. And they are actually what's keeping Medicare afloat. We need to stabilize hospital financing, so we can't have the richest get fatter while the poorest just get leaner and eventually close. And it's not that one hospital is necessarily better than the others. Often some are because they have more money, but we need them everywhere. We need it to be equitable, like I mentioned in the first couple of slides. We need to make sure that the government provides for all these vaccines, and they should be free. They should not just be affordable, because what's affordable to one is not affordable to everyone. And we need to encourage global cooperation, because this is a pandemic. This is a global health problem. It's not just in one state, one county, one neighborhood. It's everywhere. There's a lot of information on our website, but that's what I wanted to present today. And I hope that you get an understanding that this is, you know, we can't blame victims, that people are poor not by choice. There's nobody who really says, I want to stay poor because I like it here, or I like doing without. It's people, once you get into this poverty cycle, it's self-perpetuating, and it creates the system that they said they wanted to avoid, but, you know, clearly that wasn't what happened. So I hope you enjoyed this little history lesson, and I hope it puts our healthcare situation in perspective and why we are where we are, and we understand why people who seem to make bad choices often only have bad choices on the list to make. So I am open for questions if.
Great, thanks so much, Dr. Rogers. Now, for folks who are watching, you can put questions in the chat, and you can also just say nice things about Dr. Rogers for doing this incredible presentation. So a little, you know, thumbs up or a plus sign. So feel free to do that. Okay, so Catherine, if you want to take yourself off mute, you can certainly ask that question. But other folks can just put them in the chat. I'm going to go ahead and kick us off and ask Dr. Rogers a question regarding specifically PNHP, and thinking about something you and I talked about separately was the concept of where healthcare facilities are situated. One of the things I think I mentioned on email was even the fact that, say, Provident ER was closed briefly, you know, right when the pandemic started, and then also on the South Side, that for about 30 years there wasn't an emergency room. So, like, some of the has there been any? Are you aware of any studies that show clusters around those sort of like healthcare deserts?
Oh yeah, there's a lot. There's been hospital closings over the years. I mean, in the last decade, I think there's been, I'm blanking on the number, but I think it's somewhere between 200 and 300 hospitals that have closed. And this is all, hospitals closed because of the payer mix. Because if your payer mix is Medicaid or Medicare or a combination of both, and you have little private insurance, you're not breaking even. You're always going to run a deficit, and that when something comes up, they're not able to withstand it. Rural communities are being devastated, and it's really impacted on maternal services, because you can't drive 50 miles when you go in labor, or 50 miles for a prenatal check every time you need. I mean, it's just isolating hospitals where they need to be, and it is causing them to have developed these massive institutions and centers where they can make money. It's a for-profit based system. Even if a hospital is non-for-profit, believe me, they are there to make money and to build and to take over and to become a money-making machine. And then they just put that money back into themselves and they grow bigger. So the hospitals that survive are the ones that are the fattest, not necessarily the ones who are trying to run efficiently and be the fittest. And the ones that are the fattest are in wealthier neighborhoods, are in places where they have private insurance payers. So this is why there was a lack of a hospital. And if you look at the trauma center at the University of Chicago, like you said, I mean, for 30 years, we didn't have a trauma center on the South Side. And it was really a grassroots organization called The Fly, which is a group of young people who got together and protested and boycotted and did all this at the U of C that finally got this done. But trauma centers often aren't reimbursed well, because a lot of their patients, because their trauma, aren't necessarily insured. They're not coming for elective surgeries that they have insurance to cover. And so they're often money-making institutions. But if you have a public health system, Medicare for all, that would be paid. It would be covered. And there's no reason why, you know, you go to some hospitals. I went to visit a friend who was hospitalized at Northwestern, and her room was like a hotel. Even the hospital elevator looked like a hotel. It had the pictures of the restaurants in the hospital, like you go in a hotel. It tells you what restaurant to go to that night for dinner. It was the same thing, and there's no reason why hospitals, those are nice, but when you're doing that at the expense where people can't get basic care, prenatal care, basic things because of the payer mix, it is a totally inequitable system. And this is why we need medical care for all. We need to take the profit away, and we need to put medical care where it's needed, not where it can make money.
Oh, great. We've got a question that I'm going to read. As we see corporations like HCA continue to expand across the country, how do you think this will impact our healthcare system? Do you think this will make it harder to move towards single payer? And I believe HCA is I thought they were for profit, but I'm not actually 100% certain. But like the healthcare system, they are for profit. Thanks, Amy.
Yeah. There's a lot of corporations out there that are making these healthcare systems. And there's nothing about the system that unites them. It's not like we're going to be an orthopedic system or something like that, and that they're going to specialize in orthopedic. These are hospitals that accrue other hospitals so that they can make money. And they're not worried about taking care of their communities necessarily. They're worried about setting up things where they can make money. If you look at the Cleveland Clinic is in Cleveland, Ohio. It's a humongous medical center. They make billions a year, yet the neighborhoods surrounding them, I mean, right across the street, has some of the worst statistics in the whole state, and they cannot access that Cleveland Clinic. It's people come from around the world with cash to pay for things, and there's no reason why. And so we need, I think what this pandemic may show is that despite what you think, you know, this whole argument that I want to keep my employer's policy, are you going to be employed next week? Are you going to be employed next year? There's no guarantee of that. And I'm thinking the pandemic may have shown that to people, but it should show the fragility of the relationship between your job and insurance, is that you can get sick from anything and you lose your job. You're too sick to work, whether there's a pandemic or not. You're going to lose your insurance at the time you need it. Why is it that relationship exists? And again, that relationship is actually, when you look back at the history of World War II, when they developed the health insurance industry, because they wanted to provide for the people who were working in the factories, making the stuff that the country needed for war. Who were those workers? They were mostly white. So the whole industry was started on a system to provide insurance to white people who worked. It was already disenfranchising Black people. And then it continued when the GIs came home. It didn't provide them anything either. So health care based on insurance is just not disenfranchising minorities and poor people. And even people who have good jobs, you know, you can get $100,000 hospital bill without being deathly ill. And, you know, how many people can afford that? And so we all need to break away. We need to uncouple this health insurance to employment, and we need a Medicare for all system where everybody is covered, regardless of what you do for your job, or whether you're working or not, and it would equalize the services that are provided.
Got it. Let's see. Okay, we've got another question. Also from Amy, what are your thoughts on accrediting organizations like the Joint Commission is there a way for these kinds of organizations to increase healthcare equality?
You know, the Joint Commission, it's interesting, those who work in healthcare, it's a really Achilles heel. But the Joint Commission, what the Joint Commission says is that you need to have this. It's supposed to make sure that every hospital, and then there's joint commissions for clinics and dialysis and all of this stuff. And there's all these things that they do to make sure that they're safe and that they're following guidelines and they have, you know, what's best for the patient at heart. Part of the problem is one of the things that the joint commissions do is they create more steps and hoops to jump through, which is easy for hospitals with a large infrastructure of administration to take care of this, because they have the money to accommodate these new steps or new things that are needed. You get a poor hospital, which is functioning on the edge, they're not able to often accommodate that. So they're not really increasing healthcare quality. They're putting more stress, not that stress is not needed to be done at these poor hospitals, because they do need to have the same quality and safety measures that all hospitals do. It's just more difficult for them to do that because they don't have the infrastructure. A lot of poor hospitals in poor communities, rural hospitals, their safety net is maybe 3 months. They've only got revenue saved maybe to cover their hospital for 3 months. Whereas you get a larger institution like Advocate or larger things with multiple sites making lots of money, they're sitting on billions of dollars. So there's no question that they can accommodate those things. So I don't think JCAHO is really the way to increase healthcare quality. The way to increase the equality is to improve the funding, to equalize the funding that hospitals get so they can do the things that make them equitable. And they have the resources to be able to do that.
Absolutely, and I know that Tom has put some comments specifically about, say, TIF funding and real estate taxes and how that, like those things, like since you mentioned housing, and obviously we're aware here in Chicago of TIF funding, so thanks for calling that out. So we've just got about 5 minutes left, and so if people wanted to put more questions in the chat, in about a minute or two, I'm going to unmute everyone. So because I see that there is someone on the phone who wouldn't obviously be able to access the chat. You know, you and I chatted a little bit about the number of physicians of color, specifically Black physicians, and just talk a little bit about that history. You touched on a little bit about like the fact that there were sort of systemic barriers to not just entering medical school, but getting postgraduate training.
Yeah, it's I'm not sure how to politically correctly say that, but it is, you know, when I went to school, I graduated from medical school in 1979, and this was soon after affirmative action started, and it, you know, the students that I went to school with were not well received by the faculty nor by many of the other students we were with. And there's still this bias that's there. There's bias that physicians have against patients, and there's bias against medical students. I'm on the faculty at Rush Medical School, and there's issues that come up there. I mean, medical school education, the hospital environment is still an extension of what happens in the country as a whole. There's not anything peculiar about healthcare that makes that all go away. There are many Trumpers who are doctors, and I'm sure that their biases carry into their healthcare decisions. So it's not unique. What I went through, what students are going through now, through school, through my training, isn't unique in just medicine. It's with all all careers, I think. And like I say, it's an extension of what happens in this country.
Got it. Okay, I'm gonna go ahead and unmute everyone. I know there's someone on the phone. So if you had a question, like I said, we've just got a few minutes left. We've got 2 minutes left. So if someone had a difficulty using the chat and wanted to ask a question, this is your chance. Okay.
You know, one of the things I'd like to say is all of these inequities are right in front of us, but we often don't see them. And we don't understand what people go through. And the way things have become so separated and unequal, and then we don't see the vast inequity. It's easy to not pretend it doesn't exist, but become immune to or just oblivious to it because it doesn't face us every day. And I mean, I commend the work that you all are doing because you all are clearly social activists and you're involved in this. But I think that part of the problem is that a lot of the history I gave you, I think people don't know. And it's very easy to just assume that people are the way they are because they want to be, or they're too lazy to do things different, or they don't want to do the hard work. But I think that's part of addressing all of this is to, just learn history. We're repeating ourselves. We're doing the same things that we've done before I was born. We're still doing the same thing, the same policies, the same, So you got to vote. That's the main thing. You got to vote.
Well, we're not shy about that. That's in our name. But we also, know that education is a big part of making change, right? And
yep.
learning this history, we are a 100-year organization, so certainly have sort of the organizations lived through some of these changes and want to be a portal, a vehicle to educate folks and expand that awareness. And so the voting is just one component of it. But with that, since everyone is either shy or perhaps has got all their questions answered, I am going to close this out and thank everyone for attending. And I appreciate the questions. Thank you, Amy, for the questions. Thanks to Catherine Mardykes, who hosted us through her Zoom connections. Ann Jameson had to take off, our president, a little bit of an emergency she had to attend to. But thanks, everyone, for attending. Thank you, Dr. Rogers, for this incredible presentation. As I said, we're going to post this on the League's website. We're going to post the recording. And check our website for future events and on social media. Thanks so much, everyone.